Creutzfeldt Jakob disease, or CJD, and its variant form, vCJD, are part of a very rare group of degenerative neurologic disorders known as transmissible spongiform encephalopathies. These are not caused by bacteria or viruses, but by prions, infectious proteins that are even smaller than viruses and resistant to standard methods of sterilization and disinfection. CJD typically arises without a clear cause, while vCJD is associated with eating beef infected with bovine spongiform encephalopathy, often called mad cow disease. Despite their different origins, both share a common feature. There is no central nervous system inflammation. What begins as a silent incubation can suddenly progress to devastating neurologic decline. And unfortunately, both are uniformly fatal, usually within a year of symptom onset. Most cases of vCJD have occurred in the United Kingdom, with a smaller number reported in other countries. The risk in the United States is considered low, largely because cattle feed practices are different here, relying on plant-based rather than animal-based products. The prion itself is unusual in that it does not contain nucleic acid, which is why it survives methods that normally kill pathogens. Once it crosses the blood-brain barrier, it settles into brain tissue and begins causing degeneration. Neurons die, leaving behind spongiform changes, small, vacuole-like holes that are surrounded by amyloid plaque. Over time, this destruction spreads throughout the brain. There are 3 recognized forms of CJD. Sporadic CJD is by far the most common, appearing in about 85% of cases and occurring spontaneously without known risk factors. Familial or hereditary CJD accounts for a smaller percentage, linked to genetic mutations that are passed down in families. The rarest form is acquired CJD, which can be transmitted through contaminated brain tissue or neurosurgical instruments. This form accounts for less than 1% of cases worldwide. Because prions exist in both lymphoid tissue and blood, the disease is believed to be bloodborne. However, there is no available test to screen blood donations for infectivity. To reduce risk, the American Red Cross does not accept donations from anyone who lived for more than 3 months in the UK between 1980 and 1996, or who has ever received a transfusion in the UK or France since 1980. The clinical picture of CJD and vCJD differs in important ways. In variant CJD, psychiatric changes, sensory disturbances, and limb pain are often the first signs, appearing in people with an average age of about 27. As the illness progresses, patients develop muscle rigidity, involuntary spasms, difficulty speaking, impaired coordination, cognitive decline, and problems with sleep. On average, people survive about 14 months after symptoms begin. In classic CJD, the typical age of onset is much later, around 65 years. Here, the disease often begins with memory loss, confusion, and visual changes. As it advances, patients develop ataxia, paralysis, involuntary movements, mutism, and rapid cognitive decline. The disease moves swiftly, and survival is usually less than a year after the first signs appear. Diagnosing these conditions is challenging. Brain biopsy is the only definitive method, but because of the risks, it is rarely performed. Instead, clinicians rely on supporting tests. Analysis of cerebrospinal fluid may detect a protein called 1433, which signals neuronal death. Although this is not unique to CJD, it strengthens the suspicion. Electroencephalography often shows a characteristic pattern that changes as the disease progresses, first slowing, then displaying periodic activity, and finally moving into a burst suppression pattern with spikes and slow waves. MRI imaging can reveal areas of hyperintense signals in the basal ganglia, another supportive clue. Unfortunately, once the neurologic symptoms appear, the disease moves rapidly. There is no cure and no treatment to stop or even slow the process. Management is entirely supportive and palliative. The focus is on preventing injury, maintaining comfort, and supporting both the patient and the family through the course of the illness. Hospice services are often involved, whether at home or in a facility, to provide comprehensive end-of-life care. For nurses, the role is centered on providing comfort, monitoring symptoms, and supporting dignity throughout the illness. Families often need extensive education, counseling, and reassurance as they cope with the progression and prepare for loss. Emotional and psychological support is just as important as physical care. Prevention of transmission is another key nursing responsibility. While these patients do not require isolation, standard precautions are essential. Extra caution must be taken with brain, spinal cord, pituitary, and eye tissue, and with any surgical procedures. Whenever possible, disposable surgical instruments should be used and then destroyed. If disposable instruments are not an option, stringent sterilization methods, such as the use of bleach and prolonged sterilization times, are required, since normal techniques do not destroy prions. The key points to remember are straightforward. Creutzfeldt Jakob disease affects older adults and progresses quickly with dementia and motor decline, while variant CJD affects younger adults, beginning with psychiatric and sensory symptoms and has a slightly longer survival. Both are caused by prions, pathogens unlike any others in medicine, and both remain untreatable. Our work as nurses is to safeguard dignity, provide comfort, prevent unnecessary risk, and walk with families through an extremely difficult journey.